Hey everyone, and welcome. If you're a pharmacist, you know this is a topic that comes across your counter every single day: secondary prevention of ischemic stroke. So what we're going to do today is cut through the noise and get right to the practical, actionable stuff you can use with your patients right away. Let's jump in.
So why is this so urgent? Well, take a look at this number. For patients who've had a high-risk TIA, a transient ischemic attack, a staggering 8% will have a major stroke within just 2 days. That's not just a statistic, That's a ticking clock, and it's our cue to act fast and get the management right.
All right, here's our game plan. First, we'll talk about who's most at risk. Then we'll cover the foundations of prevention. After that, we're doing a deep dive into our two main toolkits, the antiplatelets and the anticoagulants. And we'll wrap up by looking at how to handle care in some really important special populations.
Okay, first things first. We have to be able to spot the patients who are in the most danger. Figuring out who's at the highest risk for another event, well, that's step one in stopping it from happening.
So what are the red flags we're looking for? Think of these as your high alert indicators. Being over 60, having high blood pressure, or a history of diabetes, those are the big ones. But also pay close attention to the TIA itself. Did it involve trouble with speech or weakness? Did the symptoms last for more than 10 minutes? If the answer is yes, their short-term risk of a full-blown stroke just shot way up. Seeing these signs means that patient needs an urgent referral, period.
Now, before we get into all the different pills and prescriptions, we have to talk about the bigger picture. Because, honestly, medication is just one piece of the puzzle. It's an important piece, for sure, but it doesn't work in a vacuum.
The bedrock of all of this, it's always lifestyle. You've got to control those vascular risk factors. That means quitting smoking, improving diet, getting exercise. That's totally non-negotiable. Then for some folks with really significant blockage in their carotid artery, we're talking 70% or more, surgery might be on the table. It's only after we've established this foundation that we bring in the pharmacologic therapy.
Okay, let's get into our first major drug class, the antiplatelets. When we're talking about strokes caused by plaque buildup in the arteries, these are our heavy hitters. And knowing the little differences between them, that's absolutely key for good counseling.
And really, this quote says it all. It's the guiding principle here. If the stroke's origin is arterial disease, atherothrombosis, then antiplatelets are, without a doubt, the cornerstone of preventing another one.
All right, let's break down our main players. You've got aspirin, or ASA. The classic issue here is GI upset, so your number one counseling point is always going to be, take it with food. Simple as that. If a patient just can't handle ASA, clopidogrel is a fantastic alternative. Just give them a heads up about a possible rash or some diarrhea. Then there's the diprodiamol/ASA combo. The big one to watch for here, headaches. Seriously, it's a super common reason people stop taking it, so telling them up front that it often gets better with time can make all the difference.
Now this is a really important point for your practice. We know clopidogrel by itself is a little bit better than ASA by itself. So what about using them together for the long haul? Well, the evidence is pretty clear. Outside of that initial acute period, combining them doesn't really give you much extra benefit in preventing another stroke, but what it does do is significantly jack up the risk of a major bleed. So the bottom line is, long-term dual antiplatelet therapy is generally a no-go for secondary stroke prevention.
Okay, so let's boil all of that down into some crystal clear counseling points. For any antiplatelet, the bleeding risk conversation is non-negotiable. You have to tell them what to look for. Weird bruising, black, tarry stools. For ASA, it's take with food or try an enteric-coated version. For the dipyridamole combo, you have to preemptively warn them about the headaches to manage expectations. And for clopidogrel, just that quick heads up about a potential rash or diarrhea can prevent a panicked phone call later.
All right, let's switch gears completely. We've been talking about strokes from arterial disease, but now we need to talk about cardioembolic strokes. And this is a huge distinction because it means we need a totally different class of drugs, the anticoagulants.
So why the big switch? It's all about where the clot came from. In a cardioembolic stroke, the arteries might be fine. The problem is a clot that formed inside the heart, usually because of atrial fibrillation, that then breaks off and travels up to the brain. And to prevent that kind of clot, you need anticoagulants, not antiplatelets.
So here, our two big choices are the old-school warfarin and the newer DOACs. And from a practical standpoint, they're worlds apart. With warfarin, you've got the constant INR checks, the food interactions, the drug interactions. It's a lot to manage. DOACs give you that fixed daily dose and way fewer interactions. But maybe the biggest selling point for a lot of people is that DOACs have a better safety profile when it comes to that complication we all fear most, bleeding in the brain. That said, for patients with mechanical heart valves, warfarin is still the king.
But, and this is a huge but, all that convenience with DOACs comes with one critical string attached. While you don't have to monitor their INR for efficacy, you absolutely, positively have to monitor for safety. And that means keeping a close eye on their kidney function. As you can see, the proper dose for a lot of these DOACs is tied directly to their creatinine clearance. That makes checking renal function a vital role for us as pharmacists.
So when it comes to counseling, the script is totally different for each class. With warfarin, you're talking about the whole lifestyle, making it to INR appointments, keeping your diet consistent, and calling the pharmacy before starting any new medication. With DOACs, the mantra is adherence, adherence, adherence. They have a short half-life, so a missed dose means their protection drops off almost immediately. And of course, for all of them, you have that bleeding risk talk, and you strongly warn them not to take antiplatelets on top of it unless the doctor has a very specific reason for it.
Okay, for our last section, let's tackle a situation that can be really tricky, and one where your guidance as a pharmacist is absolutely essential. We're talking about managing stroke prevention for patients who are pregnant or breastfeeding.
This question comes up all the time, right? And having those evidence-based answers at your fingertips is a huge part of providing top-notch patient care.
This table here is basically your cheat sheet. During pregnancy, it's pretty straightforward. Low-dose ASA is your go-to antiplatelet, and if you need an anticoagulant, it's low molecular weight heparin. You're going to want to avoid warfarin and the DOACs completely. Now, once the patient is breastfeeding, things change a bit. Low-dose ASA is still fine, but now warfarin is considered a safe option for anticoagulation. You'll still want to steer clear of the other antiplatelets and the DOACs, mostly because we just don't have enough safety data on them.
And remember, it's not just about antithrombotics. You also need to counsel pregnant patients to stop taking their statins. And for managing hypertension, which is a huge risk factor, the preferred drugs are generally labetalol, methyldopa, or a long-acting nifedipine.
All right, so let's tie this all together. What are the absolute key takeaways for your practice? Number 1, recognize those high-risk TIA features and make sure that patient gets seen urgently. 2, become a pro at counseling on antiplatelet side effects to keep your patients on their meds. 3, know when anticoagulation is needed and be ready to explain the trade-offs between warfarin and DOACs. And finally, for pregnancy and breastfeeding, remember that low-dose ASA is your safest bet for an antiplatelet.
And that kind of leaves us with one final thought to chew on. As the evidence keeps evolving, everything we've talked about today is our current best practice. But the real question is this the final word, or are we just at the beginning of a whole new chapter in how we prevent this really devastating condition? Thanks for tuning into this explainer.